Hello, I'm Orla. I'm a fifth year medical student, and today we'll be talking about health and illness and health related quality of life and the assessment tool used to assess these, which is the PROMs. My address is there on the screen if you have any burning questions you'd like to ask. Okay, so the topics we'll cover today are, as I said, health and illness, quality of life, patient reported outcome measures, and QoLs. So we have a few questions in Socrative. I'll just read them out loud for you if you're watching this after the fact. So just think about how you would define health, just to, kick off the lecture. And basically, there's a person who in 1990 defined health as three things based on interviews with people and the things they said. So health could be a negative definition, that is a lack of illness, a functional definition, that is the ability to carry out your daily activities unimpaired, and a positive definition, which would be well-being and fitness, and this is more found in the middle to higher class people. So what is the medical model? The medical model is a model whereby illness and health are very clearly defined. Illness is a deviation from the healthy state. Illness would be caused by an injury or a pathogen, so that would make you ill. The healthcare professionals would then be responsible for identifying and classifying the pathogen or injury which caused this. So that would be a very objective process. And then you would just give treatment, and most likely this would cure the patient. So this model is a very objective model, and the problem lies in the sick individual, which supposedly the medical model can fix most of the time. There are some very obvious flaws with this model, therefore it attracted a lot of criticism. Some of the big names from the medical sociology course are Ivan Illich, and so he argued that the medical system was actually did more harm than it did good, in three big ways. He argued that healthcare is expanding and creating demand that's not needed, so our life becomes medicalized. So that's social iatrogenesis. He then linked to this, argued that we have become dependent on this medical system, which has created a need for new needs for us. So that's cultural iatrogenesis, and the fact that treatments have many side effects. So that's just a clinical iatrogenesis. Cochrane from the Cochrane Review criticised the medical model because he said there was a lack of evaluation of efficacy of the medical treatments used. So, for example, the eye patches were not well based in evidence as in their use for squint. And then Navarro came up with the point that the medical model was just used to get workers back to work, and there wasn't this whole prevention of illness. It was just very much, we need to fix these people and get them working again. So we've got a little question here. Which of the following would be relevant to the medical model? The patient is a partner. Medical officials oversee the management of disease. Preventative treatment is key. And the cause of illness is a pathogen or injury. So what I wanted to get across with this question is that the patient is very much not a partner in the medical model. The whole process is overseen by medical officials who manage the disease. Preventative treatment is not the key of the medical model. It's basically fixing things that are broken. And the cause of illness, the main cause of illness would be pathogens or injuries. Okay, so another problem with the medical model and with our current healthcare system is that the healthcare system may only be seeing the tip of the iceberg of medical problems. So a study by Wadsworth in 1971 looked at 1,000 patients retrospectively over the last 2 weeks. And of these patients, 95% have symptoms, but only 20% consulted for these symptoms. So there is a huge disparity between what's the symptoms experienced and making that leap to actually reporting your symptoms and getting medical help. Scambler also did a study wherein women wrote a diary, women between the ages of 16 to 44 years, and within this diary they reported their symptoms. Only 1 in 18 symptoms would actually result in someone going for a consultation. So again, we see this big disparity here. The importance of this is that there is a large amount of unmet need, which could result in people suffering for no reason. However, unfortunately, there was a study in 1981 by Cartwright and Anderson, which showed that 14% of GPs found that half of their consultations were trivial. So it seems like the people who are presenting are not the ones who need the treatment the most. And then there's obviously this large portion of people who are not presenting at all. It's important to point out that the healthcare system has limited resources. So if everyone was presenting with all their symptoms, primary care would be swamped. So why would a person not seek help? There are many reasons, most of them quite intuitive. So there are cultural differences. So Zborowski in 1952 reported different cultural behaviours from people of different backgrounds. And you find, for example, that old American or Irish background people were less likely to voice their pain and express it. There would be people's baseline knowledge and the symptomatology. So, you know, does the person think this is serious? And they might think it's more serious if it comes on acutely and it is more severe. Within a society, we all have a sort of lay referral system where we'll ask our friends and our family, do you think I should go and see someone about this? So there's already that discussion there, which might prevent people from going any further. There would be an individual cost-benefit analysis, particularly for people who are carers or who have children. They might think, I really don't have time to go and get checked out. I have too many caring duties. And then people who give themselves self-care might be less likely to seek help, and also alternative medicines are sometimes used by people. And then there's the important question of access, thinking particularly of people who aren't so mobile and people who are old. So what has changed since the 19th century? Well, basically now there's a lot more focus on patient-centered care, and this takes into account many aspects of the patient's life. So biological, psychological, and social in the biosocial model. Within this model, the patient is the partner in decision making. You might remember that Cochrane criticised the lack of evidence for treatments. So evidence-based medicine has also taken off in a big way, and health promotion allows for a lot more preventative medicine, which would also then reduce the amount of illnesses down the line. So, for example, the NHS is promoting a smoke-free England. So back to Socrative again. I have a little a description here to read out. So after heroin was made illegal in 1905, there were many cases of GPs continuing to prescribe for heroin users up until the 1960s. Dependent users then struggled to cut out heroin when methadone treatment was offered and resorted to crime to obtain heroin. So this was a report by Daly. This historical event is an example of A, polypharmacy, B, iatrogenic harm, C, patient advocacy, and D, good continuity of care. So this is an example of iatrogenic harm, which we were discussing before with Ivan Illich. So how do we assess the healthcare outcomes? This is important in terms of deciding which treatments should be improved or which treatments are effective. So the traditional way of assessing outcomes was very objective. You'd be thinking about morbidity, mortality, complications, and adverse events. This is very obviously limiting because it doesn't consider patient well-being. Then Kranowski's performance index was one of the first indexes introduced which took into account a patient's quality of life. So it was used for cancer patients largely, and still is used sometimes today. And clinicians would assess a patient's wellness on a scale of 0 to 100, where 100 would be they're quite well, and 0 would be deathly. So this would be good for allocating resources on the ward. The problem is that this is a unidimensional measure. It's just quality of life on a scale, and quality of life is a multidimensional measure. Another problem with this index is that doctors and patients' perceptions of health and illness may differ. For example, patients might have religion and family who can contribute in different ways to their life. So what is used now very often is the patient-reported outcome measures. These are questionnaires which determine the impact of medical interventions on the patient's quality of life. They would assess things like physical well-being, mental well-being, and social interactions. So it's a very multidimensional assessment of the patient's state. This has been used very effectively. So since 2009, for example, all NHS care providers have to collect the PROMs for hernia, varicose vein, knee, and hip replacement surgeries. And it's used in many other domains as well. Okay, so now we're going to think about specifics of what kinds of PROMs can be used. So we have a patient with arthritis who's being given treatment. What kind of things do we think might bother the patient? So we have mobility, dexterity, household activities, and depression. So these are things which are quite specific to a patient with arthritis. So if we're assessing this, the old traditional objective measures wouldn't be relevant because this is quite a complex disease, which lasts a long time. It's not simply a matter of mortality. Generic PROMs, such as the SF36, do not specifically target the most debilitating aspects specific to this condition, whereas the AIMS questionnaire, so that's the arthritis impact measure, this is disease specific, and that is sensitive to change. When it was evaluated, patients with arthritis who were given NSAIDs to treat them, there was a noticeable change in the AIM score within a period of only 4 weeks. So this is definitely sensitive to change. So what we need to think about are the types of PROM. The general one, so that was the SF36, which covers 8 aspects of a patient's quality of life. These would include things like mood and energy, physical activity, social activity. Then there would be the disease-specific questionnaires, so in this case the AIMS score, and then patient-generated measures is a third outcome measure, which is patient-focused, and that's where patients identify the areas which are most important to themselves. Obviously, this is quite hard to standardize and use across the board. So back to Socrative. Our next question is, okay, which of the following features are features of patient-centered care? A, public and patient involvement in research. B, using PROMs to improve care. C, using Qualis to allocate resources. And D, a paternalistic consultation style. E, using patient-reported experience measures. Okay, so of these, public and patient involvement in research is part of patient-centered care. So is using the QoLs to allocate resources. Using PROMs to improve care is also a feature, and using patient-reported experience measures would be a feature of patient-centered care. So I haven't mentioned patient-reported experience measures on the previous slide, but these would just be based on the patient's evaluation of the treatment process rather than the outcomes. So if we're thinking about a useful outcome measure, there are certain elements we need to consider. It needs to be valid. That means that the measure measures what it set out to measure. It is reliable, so it's repeatable. It is sensitive to change, so that you can track progress. And it's meaningful, so that means that it pertains to what's important to the patient. And many of these PROMs are designed to be very feasible, so it's short questionnaires often. So that's another feature which makes for a successful outcome measure. Can PROMs be of use? So some people would criticize PROMs based on the fact that thoughts and feelings of patients will be variable over time and also between patients. So is it reliable, valid, sensitive to change, and meaningful? The patient values are meaningful by definition, and the PROMs address the overall purpose of healthcare, which is patient well-being, rather than just thinking about the objective, is this patient sickly and dying? It considers different aspects and categories of a patient's life, so it's multidimensional, which also contributes to this idea of it being a meaningful measure. Responses are quantitative. So, for example, in the SF36 score, you have categories, 8 categories, and there's the Likert scale. So that's, the scale of likely to not likely, or often to not often. This means that you can use these PROMs not only in clinical practice for an individual patient, but you can also use them in larger trials. And it is reliable. So Han in 2007 showed that the SF 36 categories for pain and mental health were more reliable scores than actually measuring blood pressure and heart rate. So PROMs are useful for resource allocation and improving healthcare. So what is a QoL? So QoLs are quality adjusted life years. And how we calculate this is we think of the impact of a treatment on a patient, which is adjusted for the quality of life that they experience. So we have the years gained of the patient when they're given a treatment, which is multiplied by the quality of life that they experience in these years. So that's the utility. Utility would be ranging from death-like in perfect health. So that's where you got a great quality of life. The debate with QoLs is that in patients who are palliative, they obviously don't have very long to live. So the treatments offered to palliative patients might be undervalued. And the other issue might be that people have different values for health, so people might rate their health quite differently. But that being said, it is said to be the best current method for resource allocation. As we all know, the NHS doesn't have limitless funds, so decisions need to be made somehow, and it's good to base it on a value which is meaningful to patients. So I have another Socrative question here. If a patient is given a drug, the course of treatment costs $4,000 and prolongs their life by 10 years. The patient states that their quality of life on this drug is 0.8 out of 1. What is the cost per QoL? So I'll give you a second to think about that. So the cost per QoL is 4,000 divided by 8, and that would be 500. Because the cost per QoL is equal to the total cost of intervention divided by the QoLs gained by the intervention. So this is a good measure for benefit to cost unit. This is how QoLs might be used to evaluate individual treatments. So I've talked through some of the main concepts of evaluating the healthcare system based on a patient-centered system. So that's thinking about a patient's quality of life. And since the resources are so sparse, we need meaningful ways of evaluating treatments. So that's largely through PROMs and QoLs. So thank you for listening. That is the end.